Let us see now regarding the survival rate of gestational trophoblastic neoplasia. It has a good prognosis with 100% complete remission rates in low-risk disease. That is where the prognostic score is less than 6. And with multi-agent therapy, survival rate in high-risk diseases is about 80 to 90%. It's quite good. When the brain metastasis is present, survival reduces to 50 to 60%. Now coming to the recurrence of gestational trophoblastic neoplasia, overall recurrences will depend upon the staging of the condition. So if it is stage 1, then the overall recurrence is 3%. Stage 2, it is 4%. In stage 3, it is 8%. And in stage 4, it is 9%. Recurrence is a little higher in the placental site trophoblastic tumor and epithelioid trophoblastic tumor, which is about 20 to 30%. Recurrence of GTN also depends upon the number of previous molar pregnancy. The lesser the number of previous molar pregnancy, the lesser is the recurrence rate. So what is the preventive measures for recurrent disease? So it is in the form of additional cycle of chemotherapy following normalization of human chorionic gonadotrophin level, and it should be given as follows. For non-metastatic diseases, it is 1 cycle of chemotherapy. For good prognosis metastatic diseases, it is 2 cycles. And for poor prognostic metastatic diseases, that is where the score is 7 or above, it is 3 cycles of chemotherapy. Now, how do we do surveillance during and after the therapy of gestational trophoblastic neoplasia? It's always done by the estimation of the serum HCG values, and it should be done every week once it becomes negative. Every week once the therapy is started. Once it becomes negative, then it should be done every 2 weeks for 3 months, then every month for 1 year, and then every 6 to 12 months for life, or at least for 3 to 5 years. I'll repeat again, that is once initially it should be every week. So once it becomes negative, then it has to be done every 2 weeks for 3 months, then every month for 1 year, then every 6 to 12 months for life, or at least for 3 to 5 years. However, whatever may be the duration of surveillance, it is advisable for the patient not to conceive for at least 2 years after completion of drug regimen, because there are teratogenic effects on the conceptus if she becomes pregnant. A few words about the placental site trophoblastic tumor. It is an uncommon but important variant of choriocarcinoma. It consists predominantly of intermediate trophoblastic cells, and it tends to remain confined to the uterus, metastasizing later in the course of the disease, and relative to its mass, tumors produce less amount of HCG and human placental lactogen, and it is relatively insensitive to chemotherapy. Hence, the treatment in this condition is hysterectomy. So here we finish about the choriocarcinoma and related conditions. Now coming to the questions. Question number 1. What percentage of cases of molar pregnancy develop choriocarcinoma? A. 1 to 2%, B. 3 to 5%, C. 0.5 to 1%, and D. 7 to 8%. I repeat again, what percentage of cases of molar pregnancy develop choriocarcinoma? A. 1 to 2%, B. 3 to 5%, C. 0.5 to 1%, and D. 7 to 8%. Question number 2. Symptoms of dyspnea and hemoptysis in cases of choriocarcinoma are due to which of the following? A. Pulmonary metastasis, B. Cerebral or brain metastasis, liver metastasis, and D. Vaginal metastasis. I repeat again. Symptoms of dyspnea and hemoptysis in choriocarcinoma are due to which of the following? A. Pulmonary metastasis, B. Brain metastasis, C. Liver metastasis, and D. Vaginal metastasis. Question number 3. According to FIGO, anatomic staging of gestational trophoblastic neoplasia, in which stage the lesion spreads outside the uterus but is confined to the genital organs? Question I'll repeat again. According to FIGO anatomic staging of gestational trophoblastic neoplasia, in which stage the lesion spreads outside the uterus but is confined to the genital organs? Whether it is A. Stage 1, B. Stage 2, C. Stage 3, and D. Stage 4. Question number 4. As per the WHO prognostic scoring of gestational trophoblastic neoplasia, as modified by FIGO, what total score is considered as cutoff for low and high risk cases? I'll repeat the question again. As per the WHO prognostic scoring of GTN, as modified by FIGO, what total score is considered as cutoff for low and high risk? A. Score of less than 4 is low risk and more than or equal to 5 is high risk. B. Score of less than 5 is low risk and score of more than or equal to 6 is high risk. C. Score of less than 6 is low risk and more than or equal to 7 is high risk. And D. Score of less than 2 is low risk and more than or equal to 3 is high risk. Now question number 5. Drugs included in the macro regimen for choriocarcinoma, that is the high risk cases, are A. Ethambutol, mitomycin, actinomycin D, chlorambucil and optineuron. B. Ecosprin, metoprolol, atorvastatin, cabergoline, vinblastine. C. Econazole, methotrexate, acyclovir, carbamazepine, obinutuzumab. And D. Etoposide, methotrexate, actinomycin D, cyclophosphamide and vincristine. Just remember the EMACO regimen which was there for high risk cases. So which are the drugs of the following 4 variables is the answer. Thank you.